At the cusp of the new decade, Nigeria's economy took an unforeseen turn. Even though we had existing challenges, the pandemic compounded our vulnerabilities. All is not lost. Through partnerships, we are managing the pandemic. By replicating this model, we can build resilient communities. Participate in the big conversation for action at the 26th Nigerian Economic Summit. Theme: Building Partnerships for Resilience. Date: the 26th to the 27th of October 2020. Register to attend at www.nesgroup.org/26. Hurry now!
Now, same 2018, we were actually responsible for 32% of the health financing deficit in Africa, about $21 billion deficit for 2018. COVID has actually come and further exposed our underbelly, showing that we don't have what it takes to provide care, under normal settings, talk less of when you now have pandemics, and especially novel viruses like COVID-19 that the world has no experience with. But the good thing is that despite the damage inflicted by the pandemic, it also showed us what we're capable of. We're able to rapidly scale up our testing infrastructure from about 5 to 71 labs in just a space of about 6 months. We saw rapid mobilization of enormous amount of funds. If you look at the CBN packages as well as what is coming from government development sector and private sector, we're looking at over 3.6 trillion naira mobilized just within a very short space of time, So we also saw very strategic partnerships being built and felt directly, the potentials of the private sector in expanding access to care if we leverage them adequately. And most importantly, COVID-19 reminded us that without health, economic development has no foundation. So today's conversation is expected to result in the establishment of a relationship framework that will accelerate the development of the health care ecosystem and move faster towards achieving universal health coverage in Nigeria. So please, just some housekeeping issues. Participants, please leave your microphones muted. If you have any questions, type them into the Q&A room or the chat room. We'll pull them together and discuss them during the question and answer session. Please endeavor to register for the summit proper if you've not done so. Links will be provided in the chat room. Thank you very much. I would like to welcome Mr. Yinka Sani, who is the director at the NESG, to welcome us formally to this session. Thank you very much.
Good afternoon, ladies and gentlemen, and thank you, Dr. Chukwu. Ladies and gentlemen, it is the 26th Nigerian Economic Summit pre-summit webinar on healthcare financing in Nigeria, realities, impediments, and opportunities. On behalf of our chairman, Aswe Ighodalo, and the whole board, I'd like to welcome you all. Honorable Minister of State for Health, distinguished Senator Dr. Nimber, Mamura, heads of ministries, departments, and agencies of government, captains of industry, members of the international community, gentlemen of the press, distinguished ladies and gentlemen. I am pleased to welcome you to the pre-summit event of the 26th Annual Summit, organized by the Nigerian Economic Summit Group, NESG. This year, we seek to engage stakeholders in a big conversation for action to shape strategic partnerships, to chart a path to recovery and build resilience for the country's economy, businesses and households, to put Nigeria in a strong position within the changing world order. The big conversation for action will be driven by a series of pre-summit events, such as this one, to kickstart discussions on the summit theme building partnerships for resilience. This will enable us to convene a wider range of stakeholders to deliberate on a broad set of thematic and sectoral issues with key outcomes. The COVID-19 pandemic has exposed the inherent deficiencies in healthcare systems across the world. In Nigeria, the perennial challenge of poor infrastructure and shortage of health workers due to decades of underinvestment in healthcare has been exacerbated by the pandemic and its economic fallout. This has brought to the fore the need to strengthen the country's health system to build resilience against future occurrences and accelerate towards the attainment of the health-related Sustainable Development Goal, SDG 3, which is good health and well-being. The COVID-19 pandemic has thus provided an opportunity we cannot miss to focus on the healthcare system and ask hard questions about the role of the private sector in investment in healthcare, how much the public sector can afford to dedicate to healthcare, the realistic standard of healthcare that Nigeria can afford to offer at scale, and how to finance these interventions efficiently and sustainably. Stakeholders in the health sector, including the federal and state government, private sector, and international development organizations, etc., therefore need to collaborate and map out innovative partnerships aimed at scaling up the finance of healthcare in Nigeria. It is our hope that today's public-private dialogue will result in outcomes with clear and decisive actions that commit stakeholders to collaborate and chart a path for the transformation of the Nigerian health sector. I trust that we will all contribute our quota and lend the needed voice and supportive steps to make today's engagement a resounding success. I wish you all fruitful deliberations. Once again, on behalf of our chairman, I welcome you all. Thank you, and God bless our country, Nigeria.
Thank you. Thank you very much, Mr. Sani, for welcoming us on behalf of the chair of the NESG. It's my pleasure to welcome the Honorable Minister of State for Health, Senator Dr. Adeleke Nimber Mamura. Dr. Mamura is a former senator of the Federal Republic of Nigeria, has also been a member of the Lagos State House of Assembly and Speaker of same house. He is an astute administrator with many years of experience in both public and private sectors. It's my pleasure to welcome him to provide us, an overview of where we currently are in our stride to achieve universal health coverage, what government is doing, what the imperatives are, and what the opportunities are that can guide the rest of the discussion for the day. Honorable Minister, sir, you're welcome.
Thank you very much. And let me welcome all participants on this webinar. And I want to thank you for inviting me to be part of this. I have been asked to speak on barriers to universal health coverage in Nigeria and building back better. I must express my delight and the feeling of being deeply honored to be invited to give this keynote address at this pre-summit event of Nigerian Economic Summit Group Health Policy webinar on healthcare financing in Nigeria. This discussion is apt and very timely, considering the reawakening that the COVID-19 pandemic has brought on all stakeholders across the world and the nations, including Nigeria. Countries have had to reassess their commitment and efforts at financing their health systems towards ensuring that universal health coverage, which is at the core of sustainable development goal, is fast-tracked. It is an established fact that sustainable investments in healthcare are vital for national economic prosperity and growth. It has even become clearer that nations that prioritize the health of their citizens are more likely to be economically productive and viable. Health was declared human right in 1940, is enshrined in the Constitution of the World Health Organization. It was first adopted at the International Health Conference held in New York in 1946, signed by representatives of 61 states, and became operational in 1948. In recent discussions and engagements, universal health coverage has been identified as a ticket that provides all citizens a right to healthcare guarantees that their right to health is protected. Universal health coverage ensures that all citizens have access to quality health care without experiencing financial hardship. Attaining or accelerating universal health coverage is aspirational for all countries, although it can be country-tailored. Nigeria has been on the rough road to attaining UHC, and while there have been few milestones achieved, there are several impediments which have continually slowed down the journey for our country. The current pandemic has further brought to the fore the inefficiencies and monumental inadequacies within Nigeria's health system. One key requirement for accelerating a country's universal health coverage is increased and sustainable domestic and foreign financing of health. Over the last few decades, the government of Nigeria has made significant efforts to ensure that the health system is adequately financed. However, there remains a significant healthcare financing gap which needs to be addressed to ensure that no Nigerian is left behind and all citizens have protection from financial hardship when they utilize healthcare services. The current estimate of out-of-pocket health expenditure is 77.5%, while the funding gap for primary health care has been estimated at 84%. Distinguished ladies and gentlemen, you will agree with me that healthcare financing in Nigeria has suffered huge setbacks as a result of the ongoing COVID-19 pandemic, which has almost crippled our economy. The resultant low oil prices over the first half of the year, combined with significantly reduced demand for crude oil, had a devastating impact on Nigeria's revenue and, by extension, a huge shock on budget allocation to health. This, unfortunately, coincided with the urgent need for financial and non-financial resources to ensure that COVID-19 pandemic is effectively tackled. The combined efforts of government, private sector actors, and external development partners have enabled Nigeria to mount a robust response to the ongoing pandemic, serving as a testament that the healthcare financing challenges in Nigeria can be effectively tackled with the collaborative efforts of all relevant stakeholders. Despite government's efforts at providing financial resources to keep the health system afloat, Nigeria is yet to meet up with the commitments on Abuja Declaration of 2001, which prescribes that all African nations shall allocate 15% of their national budgets to their health systems. The 2017 budget to health systems National Health Account report shows that we remain below the benchmark for the Abuja Declaration, as the ratio of general government health expenditure to general government expenditure was 6.6%, including a very high out-of-pocket expenditure. This, again, is above the World Health Organization recommendation that out-of-pocket expenditure should be between 30 to 40% of personal income. Mandatory health insurance is a key driver of universal health coverage, but still remains voluntary in Nigeria, though efforts in progress to make this mandatory. It is known that when mandatory health insurance is strategically articulated, it significantly increases the ability of a health system to pool resources and other financial risk protection. Nigeria still has relatively low insurance coverage, with greater percentage of existing coverage being for formal sector employees only. The uncertainties about government revenue, as well as the limited pooling of resources through health insurance schemes, continues to present a negative impact on healthcare financing. The complex and fragmented nature of our health system, inefficiencies in resource utilization, poor adherence to strategic health purchasing mechanisms, and low private sector investments in the health sector have also marred the healthcare financing landscape, making attainment of universal health coverage an uphill task. The low prioritization of preventing care and our weak primary health care systems further reduce the cost effectiveness of our healthcare expenditure, with a resultant higher expenditure on curative tertiary healthcare services. Dwindling development assistance for health, malalignment of priorities between the national government and donor agencies, duplication of efforts by development partners, and persistent verticalization of healthcare financing from external donors have all contributed to impeding the progress on the healthcare financing goals of the health system. Despite these existing challenges, there are current strategies by the government of Nigeria towards ensuring that the healthcare system is strengthened towards resilience. The implementation of the Basic Healthcare Provision Fund holds a promise for increasing domestic resource mobilization for healthcare in Nigeria, as long as the government continues to ensure that at least 1% of the Consolidated Revenue Fund is made available for the Basic Healthcare Provision Fund, while advocating for increased contributions to the Basic Healthcare Provision Fund by private sector actors and development partners. Nigeria is poised towards leveraging experiences from the previous successful programs championed by the government of Nigeria. And these include the Saving 1 Million Lives program and the Primary Healthcare Under One Roof program. Lessons from these initiatives could be used to champion tailored building back interventions post-COVID-19. In order to ensure efficiency and strategic purchasing of human resources for health, the SOML P4R presents huge lessons that could ensure value for money and cost effectiveness. By extension, this can also be replicated in our health institutions for maximum output and value. The Primary Healthcare Under One Roof coordination and governance further presents yet another great lesson for consolidating the existing governance architecture as outlined in the National Health Act 2014. Having established that is strengthening our primary healthcare systems and facilities is the most inclusive, effective, and efficient approach to advancing our healthcare, universal healthcare aspirations as a country for the social, mental, and physical well-being of our people. It is important that primary healthcare is prioritized for investments and attention. This is currently being championed by the National Primary Healthcare Development Agency, but more efforts are required to fill the existing gaps to fast-track the anticipated progress. Consolidated efforts are currently being harnessed to advance a mandatory and people-centered national health insurance. In a bid to further strengthen the mandatory health insurance, a cross-subsidization policy must also be put in place to ensure that an increased proportion of the populace is enrolled for health insurance. Innovative strategies must be employed to make sure that the informal sector is also duly covered. Distinguished ladies and gentlemen, whilst we collectively work to reduce overdependence on the foreign agencies, I make bold to say that healthcare financing is clearly the responsibility of all stakeholders in the health system, with the government taking the lead. The private sector has a major role to play towards healthcare financing through sustainable investments in health, while the government of Nigeria continues to anticipate unwavering support from development partners until domestic investments in health are enough to make us self-sustaining with minimal need for external donor support. It is imperative that we increase domestic resource mobilization for healthcare while ensuring efficiency in health spending and implementation of intervention. Permit me at this juncture to say that with sustained and concerted efforts from all key stakeholders, Nigeria's universal health coverage aspirations through a resilient health system with adequate financing will be attained in no distant future. But we must be guided as a country to note that universal health coverage is aspirational and not a destination. All we need is country ownership and unwavering commitment. I want to reiterate the federal government's commitment towards revamping our health sector through strengthening the primary healthcare system and ensuring that we garner all the support required for increasing domestic resources for health. As a government, we are committed to mobilizing resources for healthcare in a way that will guarantee sustainability and increased efficiency. May I also inform that government remains committed to advancing existing private sector partnerships, while also welcoming new and strategic investments as we address challenges around healthcare service delivery, pharmaceutical products, supply chain, and logistics management. Enabling policies will shape our renewed partnership with the private sector for increased investments in the health sector. I must also reiterate that universal health coverage is not a one-size-fits-all. It should be country-tailored, and collectively, we have chosen to define the trajectory that will work for us as a nation. As a country, we have the firm belief that our universal health coverage aspirations are attainable, and with your collective support, we will all stand strong and tall. I wish to specifically appreciate President Muhammadu Buhari for his sustained support for the health sector and his outstanding leadership as Commander-in-Chief. I would also like to thank our development partners like the World Health Organization, the World Bank Group, the Global Fund for ATM, United States Agency for International Development, United States Center for Disease Control, United Nations Population Fund, Department for International Development, Bill and Melinda Gates Foundation, and a host of others who have continued to support Nigeria's efforts towards improving the healthcare status of all citizens. My profound gratitude goes to all private sector actors and non-government entities like the Dangote Foundation, the Maker Ofo Foundation, the MTN Foundation, and others that are playing various roles towards increasing investments in the health sector and optimizing the health of the populace. I want to specifically appreciate and applaud CAR COVID. You are the true heroes of our time. Your strategic, timely, and spontaneous support has set the tone for private sector partnership in Nigeria, and the Nigerian people will forever remain indebted to you. It will be unpardonable if I fail to deeply appreciate the Nigerian Economic Summit Group, who over the last few decades have robustly supported the government of Nigeria, not just as a think tank, but has provided a conducive platform for birthing cutting-edge ideas for systems strengthening through public-private dialogues on contemporary issues. You have further provided an economic lens for valuable input that has informed policy formulation across different sectors in Nigeria. I thank the Nigerian Economic Summit Group for providing these opportunities for discussions on the intersection between the health sector and the economy, and hope that this webinar will catalyze increased investments and support for the health system by all private sector holders in Nigeria. We recognize the fact that a healthy populace will translate into a wealthy and economically prosperous nation. Hence the reason healthcare has remained a key priority for the government. The government of Nigeria will continue to foster strategies and partnerships that will accelerate universal health coverage for all Nigerians. I thank you all for joining this webinar and for the invaluable contributions that will make in the course of the discussions. I implore everyone to work assiduously and sustain the momentum to increase domestic healthcare financing and foreign investments in health until Nigeria is able to successfully health coverage. Fruitful discussions. I thank you for your kind attention.
Thank you very much, Honorable Minister, Senator Dr. Mamura, for that very detailed outline of where we are and the challenges we face, as well as government commitments to work together with the private sector. It was very refreshing hearing you say that over and over again, that government is committed to crowding the private sector, work better to coordinate development partners, but most importantly, lead in increasing domestic financing for health towards UHC. Thank you very much. So we'll quickly jump over to the panel session. As you would have seen from the flyer, we have a panel of very distinguished Nigerians and, Nigerians in diaspora. That was kind of a way to put it. So to quickly introduce them, we have with us as on the panel for today, Mr. Ben Akabueze. Mr. Ben Akabueze is an economist and the current Director General of the Budget Office of the Federal Republic of Nigeria. He served previously as the CEO of Now Bank and was a 2 times Commissioner for Economic Planning and Budget with the Lagos State Government. We also have the CEO of the President of the African Export-Import Bank, Afri-Exim Bank, Professor Benedict Orama. Professor Benedict Orama is ably represented by Ms. Oluranti Doherty, who is the head of export development at Afri-Exim Bank. She oversees the implementation of the bank's health and medical tourism program, as well as products and initiatives that support the health medical tourism programs. She also oversees the implementation of the bank's products and initiatives in the support of export-related projects in agro-processing, light manufacturing, and hospitality sectors across Africa. We also have the Executive Chairman of the Federal Inland Revenue Service of Nigeria, FIRS, Mr. Mohammed Mamanami, who is ably represented by Mr. Bonjubola, the Director, Tax Policy Department. We again have on the panel, Mr. Kunle Elebute, who is the Senior Partner at KPMG Nigeria and Chairman KPMG Africa. Kunle is also a member of the KPMG Global Board, as well as KPMG Europe, Middle East and Africa Board. And then we have Ms. Elaine Barua, who is the Principal Associate International Development with Abt Associates in US. Ms. Baroa is an international development specialist with over 15 years of experience working on health financing across different countries, including Nigeria, Haiti, Ethiopia, China, and Bangladesh. We have from the World Bank, Dr. Olumide Okunla. Dr. Olumide Okunla is the program manager for health for IFC/World Bank in Nigeria. Dr. Okunla is a medical doctor and health economist and a renowned health financing actor within not just the country, but across the continent. Dear esteemed panelists, you're welcome to this session. Thank you very much for making our time to join us. I would like to start with Ms. Elaine Baroa. Ms. Elaine, you're quite familiar with Nigeria, and you've also worked on health financing, supporting economic evaluation and health financing reforms across other countries, including not just countries in Africa, but some of the Asian countries as well. So it would be nice to hear from you. What are the lessons we've learned, at least in the last decade or so, in health financing reforms towards universal health coverage, particularly from countries who are resource constrained or in same developmental phase as Nigeria? What lessons have we learned from those who've made progress, as well as from those who haven't? What do we know now that we didn't know before? And what are some of the options that are backed by clear evidence that Nigeria should be considering? Thank you very much. Over to you, Ms. Elaine.
Thank you very much, Nkata. I hope everyone will allow me to stand on the existing protocol that have been laid out by Mr. Sani and Dr. Chukwu. I'd also like to have share my thanks to the Nigerian Economic Summit group for inviting me. It's wonderful to participate on a panel like this, which covers such a broad audience, everyone from Ministry of Finance to the banking sector to the internal revenue sector, because I think we're going to touch upon all of them in the next 10 minutes that I'm talking with. And I want to say thank you as well to my distinguished panelists. I'm really looking forward to learning from you. It's nice to be on a panel that is not just health economists. So to answer your question, I think there are several lessons that I want to cover in the next 10 minutes that I think are really important. The first one I think that I want to state is that when we talk about health financing systems, we have to really talk about systems, not individual schemes. We cannot, no country is able to achieve universal health coverage or move towards universal health coverage by using one model or one scheme. It's not just savings accounts or just health insurance or just government paying for everybody. It has to be a combination of models and approaches that make up the health financing system. And I'm going to talk about what a health financing system does in just a second. So we shouldn't confuse individual models with a system, a health financing system. The second lesson that I want to share would be the role of government. Research, experience in the global sector all says the same thing. Countries that have made progress towards universal health coverage did it with the majority of the financing coming from the government. There is no magic bullet out there. It is just the government. The majority of the financing comes from the government. There are other things that people spend a lot of energy doing, looking for money, magic pools of money in the private sector that can be absorbed by the health sector. Those magic pools of money don't exist. No one has found them yet. So we shouldn't be spending too much energy on what we think of as innovative financing, where our innovation is finding money that nobody else has located. If it was there, somebody would have found it and somebody would have been spending it by now. So we shouldn't be thinking of innovating financing in terms of pools of money sitting around waiting to be spent. The last point that I want to make, which I don't need to spend much time on because we're going to get there pretty quickly, is no country has made progress towards universal health coverage by using payroll-funded social health insurance schemes. It doesn't mean that countries have not made progress using health insurance schemes, but it does mean that we don't make progress towards universal health and coverage using payroll-funded health insurance schemes. And I'm going to talk a little bit more about countries that have made progress using health insurance and why they were able to make that progress. So those are my 4 lessons. So let's go quickly back to the beginning and talk about models versus schemes. We need different models within our health financing system because our health financing system has to do 3 things for an entire population. In universal health coverage, we are not talking about coverage of insurance. We mean coverage, effective coverage means able to access the services that we need. There is no point having some sort of financial coverage if the effective coverage is not there. So if someone else is willing to pay, but there is no health facility nearby, then I don't have effective coverage. I just have some financial coverage. The second thing in universal health coverage that gets lost is the universality. If we're looking for models to put in our health financing system, these have to be models that actually have potential to be universal. That's one of the reasons no country makes progress towards UHC through payroll tax. Payroll tax in countries with large informal sectors, it simply won't work, all right? Because if you need people to be on a payroll to be able to take out health insurance premiums, you'll only max out at the size of your formal sector. Countries like Nigeria, with massive informal sectors, nearly 3/4 of the population essentially is in the informal sector, a payroll scheme isn't going to be effective. But again, I know that we have a health insurance scheme like that in Nigeria, so I'm going to come to that in a second. So these systems, health financing systems, have to do 3 things. They have to raise revenue to be spent on health. They then have to decide who they're paying for, and then they have to decide what they're paying for. It is because we have to do these things for different populations that we need systems, not individual models. So let's talk about who we're paying for first. The focus of my examples that I'm going to bring today are informal approaches that work for informal sector. But that leaves out two groups, right? So the poor informal, the poorest in a country, is the same everywhere in the world from global experience. Government pays for the poorest. There's no other way of doing it. For the wealthiest, at this point in time in 2020, every country in the world has some sort of private health insurance system where people can voluntarily purchase health insurance to cover themselves. It typically covers the wealthiest in a country. And we might be tempted to say, well, let's just let them pay for their health insurance and go. They're part of a system and they can have negative spillover effects. So for example, there are countries like Kenya and South Africa, where although the voluntary health financing is a small part, Kenya it's less than 2%, South Africa it's about 16%, those people consume much more than what they're putting in. So that 2% in Kenya consumes 10% of all health spending. That 16% in South Africa consumes 47% of all the spending on healthcare in South Africa. That has consequences because what it means is infrastructure investments, doctors, nurses, they all get sucked into that sector that's paying, and that means there's less for everybody else. So there are consequences to having and leaving unregulated private health and voluntary insurance schemes. So let's deal with then the middle. So the middle is the informal sector. So we need to raise money for them. We need to choose who we're going to pay for, in this case, that sector. And then we need to talk about what we're purchasing. These require different functions. There are many different ways of doing it. So we can raise money through taxes. We can raise money by asking people to pay. Money can come from people paying out of pockets. Fortunately, the Honourable Minister pointed out, obviously, that's not what we want to do. But there are different ways of doing each of these functions: collecting money, pooling the money, and purchasing. So, second point that I want to make then, aside from the fact that health systems are complex, we said
Elaine,
money
please.
comes. Yes.
Hi, Elaine, please, you need to start rounding up.
Absolutely.
Yes, thank you. Thank you.
Where the money comes from, it has to come from government. The lessons out there suggest money must come from government. Either it comes from improved tax revenue, or it comes from government increasing their share, their allocation, or it comes from strengthened budgeting processes. These are things that have worked in countries where increased revenue from government has driven UHC. Reprioritizing more money out of the existing government. And the final area is technical efficiency. This is where we can apply innovation. And it's so good to see this panel, because innovation doesn't typically come from within government. We have a private sector innovation examples across the world. So for example, public-private partnerships that can work to create more money for vaccines. South Africa has a great research and procurement public-private partnership called BioVac that you should look into. Peru does a great job of contracting private sector to run public sector elements of public sector facilities, so that ministries of health are not in the business of trying to provide service, but are more in the business of making sure those who need care can receive care. And so my final point, and it'll take me just one more minute, payroll funded health insurance and where the money comes from. So like I said, innovative financing does not raise adequate amounts of money. We have no evidence to show that it does that. Earmarked taxes also do not raise adequate amount of money to move a country toward UHC. Countries have done it through health insurance, but even that health insurance requires significant government contribution. So where we've had massive increases in health insurance, effective health insurance coverage, the two examples people will quote would be China and Rwanda. But there are certain criteria that worked for those countries. First of all, very politically powerful central governments that could direct lower levels of government, and lower levels of government implemented. Secondly, there were either incentives for government officials to get people enrolled, or it was just made a performance criteria in the case of China. Thirdly, it was not voluntary, it was mandatory. And that mandatory nature was effective. So in Rwanda, it's illegal to not have health insurance. In China, because there are performance criteria associated with enrollment for government officials, they ensured their populations were covered. And then the fourth most important aspect, massive subsidies. In China, massive subsidies, 80% of the premiums paid came from government, not from individuals. In Rwanda, the scale up happened when donors were prepared to pay and contribute massively to the subsidization effort. So that brings me back to the beginning of what I was saying, basically, which is that countries that have moved the dial towards UHC have done it through massive increases in government expenditure on health. And they've done that also through improving the efficiency with which their health system delivers that health. Back to you, Nkata.
Thank you very much, Elaine. I think, thank you very much. Well, we can't argue against evidence except when we have better evidence. But I'll just like to say that you've nicely set all of us up because we're all Nigerians. We know the reality of dwindling revenue even before COVID, with the issues around oil prices, and now with COVID. So that brings us to the big question, which I think I was going to ask Mr. Ben, who has the difficult task of really worrying about, the budget, balancing it, and all the different priority sectors and all that. But I think I would like Dr. Okola of the World Bank to maybe just take 2-3 minutes, just so we're not putting all the pressures on government, right? Dr. Okola, World Bank supports government across a lot of areas, infrastructure, and is also heavily vested in supporting government across the social sector. What's the landscape like? What's our reality from your view?
Thank you very much, Dr. Nkata. And coming right after the points Elena has made, you've made my work a whole lot easier. One thing I would say right off the bat is that nobody wants to be in Mr. Benakabue's shoes right now. And I must really commend what himself and his team under the leadership of the Minister of Finance have done in terms of responding to the ongoing crisis. People seem to forget that actually by January, February, what Nigeria was dealing was first the oil shock, which was highlighted by the Honorable Minister of State. Then we had COVID. I mean, this were not things you will get from the best economic schools. There are no playbooks to deal with what government across the world, and indeed in a country like Nigeria, had to deal with. Now, I would only just quickly, in terms of the realities you asked, do a deep dive on what Eileen has just said, and we totally agree with it. No country in the world, let's be clear about it, and I will just also reiterate it. No country in the world has been able to achieve universal health coverage without public financing. It's a sine qua non. But then public financing is a product of two factors: your fiscal capacity and the priority that you give to health in your budget. Fiscal capacity, perhaps, of course, is what Mr. Ben will be telling us in terms of where things are. But these are the things that we know so far. Recall, in 2016, Nigeria was in recession. And only in the last 2 years or so, we're just gradually coming out of recession, to the extent that we got a GDP, tax to GDP in the region of 8%, growing at about 2.2 annual growth rate. But with COVID, with the oil shocks, it's predicted that we're moving back towards as low as 5%, which might even go lower. So, and therein lies the challenge. So if we say public financing is key, where will this money come from? So, but as I said, this is a product of two factors: your fiscal capacity and your prioritization. So on fiscal capacity, it's reduced and it's even going further down. Prioritization, that's the one we probably have the most influence. But why should we prioritize healthcare? And that perhaps that's what I can talk about. And then I leave Mr. Ben to look at what they are doing in terms of growing the economy, in terms of expanding the fiscal space. Look, right now, Nigeria, if you compare Nigeria to its peers, India and a few other countries, Mexico, those countries have undergone what we call a structural transformation. They've moved from the sequence that's described from the agri sector to the industrial sector to services. Countries like India have jumped over industry and moved to services, and actually making a whole lot of money from things like ICT. So services sector is something that's based on the kind of human capital that you've been able to accumulate. So in short, the future of Nigeria is based on the quality of our human capital. So that is why we need to emphasize, even when things are tough, we need to emphasize additional financing for things like health, for things like education, because that is the future of Nigeria. The second thing is that without health, we will not be able to have the kind of innovation and creativity that we require. Let me just quickly round up by saying, as health policymakers in the sector, maybe we need to also make a few comments on the fiscal side as well. I do agree, yes, that the evidence is probably not strong as Elena said, in terms of innovative financing. But right now, Nigeria is a country that probably would need to use the kitchen sink approach. If we need to earmark like BATPF, if we need to get innovative financing, I'm happy that the FRS Director General is on this call. Look, there will be, if you put health bags, what people call sin taxes, alcohol, tobacco, beverages, I'm adding betting onto that. That can even go, and you earmark it to health, we can even get at least an additional increase in that fiscal space for health. So I wouldn't necessarily throw all of that out. I would say we just need to be creative and innovative in the way we harness all of these ideas. Back to you, Nkata. Thanks.
Thank you very much, Dr. Okola. You clearly just passed the bigger parts of the bigger ball to Mr. Ben. But I like the way you ended it. The reality is we're not in a good place, and there is no economic school book for this particular situation. So we might eventually have to be those who are running with the traditional, but then are taking on every additional that comes from everywhere. Because right now, every little counts. We basically need everything we can lay our hands on. Mr. Ben Akabo is a DG budget. Before I invite you to speak, I just want to say another big thank you. I know you had all sorts of clashes today, and this is probably the second time in a month we're dragging you into a health event to again discuss how to, finance the health sector towards UHC. Thank you very much. You're welcome. So, well, I don't even need to ask any specific questions. You can already see what the conversation is. So how do we really, with all the evidence that the fastest track towards UHC is mostly with public financing, how do we deal with the current fiscal situation we find ourselves in? Thank you very much.
Well, thank you, Nkata, and thank you, Honorable Minister, co-panelists, and distinguished participants, everyone. Health financing is a very important subject, and that's why it's one that I always try and make time for, because I think it's, for us as a people, it's an existential issue. I do agree with Sister, Elaine, that as well as Dr. Olumide, with whom I've had several occasions to, talk about this subject. I do, accept that UHC requires, majority, funding from, government, but and I'm not even going to contest at all the fact of inadequacy of, funding for the sector currently, because that's reality. And as I say to people, but then the point is, it's not necessarily reflective of government's lack of intention to prioritize, to accord the sector the required priority, but more a reflection of government's reality. Today, as a country, we have about the lowest public sector revenue to GDP ratio, even in the entire world. We are currently at just over 8%. That's about half the African average, not to talk of the sort of levels that they have in some of the countries we call our comparator countries, whether they're the mint countries or the BRICS. And so that limits very significantly our capacity as a government to intervene as much as we should. The other thing to note is that in our own constitutional arrangement, there are 3 tiers of government, and health is on the concurrent legislative list. Each of these tiers of government, federal, state, and local governments, have constitutionally guaranteed shares of revenue, as well as taxing authorities. But oftentimes, because it's the federal government's budget that has visibility. People equate the federal government's budgetary provisions as the entirety of budgetary resources allocated to health. But the reality also is, given the way the responsibilities of each tier of government stack up, the lower levels, the state and the local, should actually be contributing, be spending a larger share of their budget on health. They're not, because at the federal level, you've got things like defense, national security, foreign affairs, immigration, all those sort of things that the state have nothing to do with. Whereas the states are to focus more on the social sector, the health, education, infrastructure within their, so their allocation to health should exceed that of the federal government as a percentage of the budget. And so when you speak about the Abuja Declaration of 15%, it's, when you read that declaration, it says countries, 15% of their national budgets. Some of the countries on the continent have their constitutional arrangement is such that they have a national budget. We don't have a national budget in Nigeria. You'll have to aggregate all of the budgets of all the tiers of government to arrive at a national budget. And that's something we're beginning to simulate, at least for the federal and the state governments. And in the next few weeks, we'll have that out for last year and the current year. So people begin to get a better sense of how much actually is being allocated to sectors like, health. But let me just share some slides that, underscore this point that progress is being made, even though perhaps not nearly, fast enough, so I'm sharing my screen now, trying to share my screen. Is anybody, can you see my screen? Am I able to share my screen? Hello?
Yeah, you should be able to, because we made you a co-host.
Okay, so.
But I can't see.
I can share my screen now. Okay. You can see, right?
Yes, we can.
All right. Okay. So let me just, okay. If you look at this screen, for instance, it will show that, okay, over the 5 to 6 year period, actually leading up to 2015, the FGN, budget for the health sector, stagnated. Okay. But then when you look at what has happened from 2015 to 2020, after 2015, from 2017 to 2020, you will see annually that there has been some growth. And so over the last 5 years, we have seen basically a doubling of that from, in terms of the budget reallocation to, to health. But mark the point, I'm not, even trying to contend that this is adequate, but just to show that there's progress being made. And some of this progress has been made possible by some, deliberate actions or strategic, actions and agreements, whether they be agreements or legislation. So for instance, we signed the Gavi transition plan that committed us to step up, financing, for vaccines. We, basically activated the Basic Healthcare Provision Fund, which then also improved the flow of, resources to, the sector. And these have all helped towards improving the, the budgetary contribution. So when you see here also the, the next slide here, we're also stepping up even FDN's contribution to the health insurance scheme, the National Health Insurance Scheme, which I do totally agree with Elaine's point that the sustainable way forward is to make this mandatory for all, whether you choose to use the services or not. Everyone should contribute, and that is the direction of policy. This slide also basically shows the commitment that we've made, even going forward in terms of funding for vaccines. We see here over the 10-year period, the 10-year transition period going up to 2028, okay, the total estimate for vaccine is just tops $3 billion. But here, the federal government has committed to only covering $2 billion of that, and Gavi $1 billion. You see the chart there. As we approach 2028, you see that Gavi's contribution drops off. Even the World Bank financing, which is to bridge the gap, also drops off till we get to 2028, by which time government is projecting to assume responsibility. And this is really, strictly speaking, not a responsibility that should belong to the federal government, but to all the tiers of government. But we have states. Some states are about almost 100% dependent on donor and federal government financing for vaccines. If you look at their budgets, they make absolutely no provisions for this, and this cannot continue. If you look at even a scheme like the basic healthcare provision fund requires a matching contribution by the states. Now the state governments are busy asking for waiver from making their own contribution. So it's only the federal government's contribution that will be available. This will not, basically help with, providing the sort of resources that are required, for the health sector. There are some states where the loan, or sometimes two federal, tertiary healthcare institutions in the state shoulder the bulk of the burden of secondary healthcare in those states. The state governments are, in some states, even, the number of medical doctors employed by the federal government serving in the state are, more than 10 times the number of what, those in the service of the state government. States and federal governments need to step up. When I used to work for Lagos state government, I remember, the state government decided to, set up what they called model health, primary health care centers in all the 57 local government and and local council development areas, and to use that to, illustrate what is possible. These things can function on 24/7 basis and carry a lot of the healthcare needs of the people. And the idea was to encourage the local governments. I remember my colleague then in council met with the local government chairman to try and persuade them to this thing. And the response that he got was that, investing in healthcare does not win elections. In other words, the people don't even seem to hold government accountable for healthcare. When it's election time, health, care issues are not, they're not one of the top issues on the table. So if the politicians are being held for how many kekes you will provide for us, what you will do, how many grinding machines, basically the local government chairman was saying that that's what they will focus on. So this is, again, for those of us who are in the advocacy space, if the people don't put this demand on the other tiers of government to, for better investment in health, it will be difficult to get us to where we are. Let me also note, in terms of government support, that the health sector is probably the only sector I know of in Nigeria where public sector compensation is higher than the private sector level. And so when people talk about government not taking the sector seriously, that's not correct. This is the only sector where the public sector employees are paid better on the average than private sector employees. It doesn't happen in any other sector that I know of. Okay, so as I'm saying, all of these charts basically just show the commitments that we have made to scaling up, at least on the the federal level, funding for health. But my comment before my time runs out is to underscore the point that the Honorable Minister State Health made, which is the need for development partners to align with national objectives and programs. And I remember an example when I worked for Lagos State government. There had been a study by another development partner, in partnership with ourselves, looking at the maternal mortality issue. And we knew what the rates were. We knew what the burden was. We then had a plan to work that down. And one of the things we identified that could help was something as little as something called Mama Kits, just providing these kits for all pregnant women when they come for the free antenatal service that the state government was providing. And another development partner showed up and said they wanted to do an audit on, a study on maternal, and what we said, listen, we have a study by another. We've identified what works. We're looking for money to scale up what works. Can you put your money into what works? That has been established. They said, no, they must do another study. And I said, you can keep your money. We don't need your money to do another study. If you're not prepared to align with, the program of what works, then, we don't want another study. So, I just thought I'll end on that point.
Thank you very, very much, Mr. Ben. It's impressive how, despite sitting on the very hot seat, you never shy away from coming out to engage and show the commitment that we're all working towards the same goals. I think it's clear that we have the issue of this: how do we get additional funding for health? The priority issue, increasing our fiscal space, doing whatever is possible within our realities. And the other issue which has kept coming up from Elaine now to you, Mr. Ben, which is around inefficiency. Elaine talked about technical efficiency, right? Again, you're giving examples of the sector the only sector where those in the public space are paid more than those in the private space. I don't have anything that says this is better or that's worse in terms of who should earn more. But the key thing is, what is the outcome of that investment, right? Because one of the big inefficiency areas we have is we currently pay for inputs and count inputs the way we finance health. Number of ambulances bought, number of hospitals built, number of healthcare workers recruited, right? Not number of people who received any kind of care, So we need to really start looking at how to leverage the private sector, not just to increase financing, but also to increase technical efficiency by either helping us do things better or by actually taking over, outsourcing some of these services to them. So I would want to bring on Doherty. Afrexim Bank has a large portfolio in health, and I'm aware you have projects in Nigeria and around Africa and engaging with the private sector. So not just to look at it from an Afrexim portfolio, but looking at it from how do we actually crowd in the private sector? What do we need to do to get the private sector to play a more strategic role, right, in being that partner that brings in investments as well as improves the efficiency of delivery. Mr. Doherty, thank you.
Thank you so much, and good afternoon all. Good afternoon to the Honorable Minister of Health. Good afternoon to the Director and ESG, and ladies and gentlemen. It is indeed a pleasure for Afreximbank to participate in this pre-summit. My President, Professor Rama, extends his esteemed greetings to you all, and he was unable to make it to this session because we have our board meetings going on right now, which is chairing. I thank all my co-moderators and co-panelists, and I must say this has been very interesting discussions. I note very well that whilst the main trust has been that, for us to achieve universal health coverage in Nigeria, it must be driven primarily by the public sector. However, in the bits of information or bits of discussion that was made, I note that a lot of my co-panelists have also referred to the fact that there are roles for private sector, to the fact that there are roles for improving technical efficiency, innovation by private sector, to the fact that even in considering funding of this healthcare sector in achieving universal health coverage, we also need to explore beyond the traditional means of government funding. I would like to start off by giving a background of Afreximbank. It's a multilateral trade finance institution established in 1993 under the auspices of the African Development Bank. So it's has as member countries 51 countries, including Nigeria. I would go on to share the importance of private sector involvement in the healthcare. If you recall, all across Africa, the demand for quality healthcare has been increasing. Even before this COVID-19 pandemic and that exposed some of the gaps in our healthcare system, studies had estimated that between 25 to 30 billion in new investment is needed in healthcare assets to meet the growing healthcare demands of Africans. What we know right now is that it's clear that governments, and not just Nigeria, but governments all across Africa, will not be able to meet this health costs just all on their own. And this is in view of the huge financing gap and also the changing disease profile on the continent. Therefore, private sector must play very big roles in helping to improve healthcare. So where are the investment opportunities, or what do we think are the roles that private sector can play in healthcare? The private sector have a lot to do in healthcare. They serve as health service providers mainly across the country. We see a lot of private sector run hospitals providing primary care, providing secondary care. We see private sector players involved in retail and distribution of pharmaceutical drugs. We see private investment coming into the development of secondary and tertiary care provision. We see private sector coming into the financing entities such as insurance companies and other risk pooling entities. Where we've not seen private sector play much role has been in the medical education and training institutes, but there are roles there. There are, in view of the fact that there are many innovative technological solutions available in terms of e-learning platforms, in terms of telemedicines. There's such big roles for private sector to play. And then coming back to the COVID-19 pandemic and the needs that has arisen with regards to us being able to manufacture at least basic medical equipment and consumables locally, there's also been a need for manufacturing of pharmaceutical products. Looking at us at Afreximbank, we've been trying to channel private sector financing into healthcare. We are a multilateral finance institution, and so we believe that, in as much as public sector funding is required, there is also a place for multilateral finance involvement. So Afreximbank has been at the forefront of health sector development on the continent. We developed a health and medical tourism program, and with that, we've been able to support development of infrastructure in member countries like Nigeria, Liberia, Uganda, to mention a few. More importantly, we decided to try and change the healthcare landscape on the continent, because we went into a partnership with King's College Hospital London, asking them to do a feasibility study on the continent and to see where the gaps are and where we as an institution can help in bringing in private sector investment into healthcare. And one of the key areas that was identified was infrastructure gaps and setting up regional medical centers of excellence to try and bridge this infrastructure gap. I'm happy to inform you that we are going ahead with the development of our first African Medical Center of Excellence, which would attend or cater to the needs of West Africa. And Nigeria would be the location for this center. Nigeria was selected as host country following a bid by 4 other countries, Kenya, Tanzania, and Ghana. We secured the land in Abuja with the help and cooperation of the Federal Ministry of Health and the goodwill of the Federal Government of Nigeria. We are going to commence the development of a 500-bed facility from Q1 2021. And this center will provide care in oncology, hematology, cardiology, and general healthcare services. We are hoping to be able to attract up to 200 million in investments into the Nigerian healthcare space. We are using this project to crowd in investment into the space. We know this cannot solve everything or totally address the problems that are in the healthcare sector, but it will go into trying to move the needle. Furthermore, the bank has been providing support across the healthcare space. We had a specific facility, a 200 million facility that we developed in conjunction with UNECA. We want to use that to support manufacture of medical equipment and consumables on the continent. We are giving this loan out at special pricing, and we are inviting medical consumable manufacturers or interested organizations, healthcare, private sector organizations who want to go into this field to come in contact with us, and we will be able to support them and assist them. We've also been collaborating with the African COVID-19 Vaccine Financing Initiative. This initiative aims to arrange a financing facility of up to 5 billion to enable African countries procure COVID-19 vaccines in a timely manner when they become available. The funding is being led by Afreximbank. We have committed to about 1 to 2 billion into this Africa COVID-19 Vaccine Financing Initiative. We also assisted to establish the African Medical Supplies Platform. This is a platform where African countries can access to purchase medical equipment, medical consumables, etc., as during this COVID-19 pandemic, as the supply chain in medical supplies become affected. Furthermore, the bank also made a 3 million grant donation to its member countries to support them. With all this the bank is doing and has done, we have put in other financial interventions to be able to support private sector actors beyond providing debt financing. We have a project preparation facility that can support private sector promoters to develop bankable projects across all these fields I have mentioned, from setting up healthcare infrastructure to telemedicine, to franchise financing, to retailing in pharmaceutical products. We also have an advisory and capital markets unit that can sit with project promoters and developers to see how to attract equity investors into their projects. And finally, the bank has a fund for export development in Africa. This is an equity fund that the bank developed, and it focuses on healthcare sector projects. And this fund is willing to invest in healthcare projects across our member countries, including Nigeria. For us, we've learned a lot, and we believe strongly that, we need to be able to attract and bring in the private sector into helping to develop healthcare sector to make it more efficient. We believe if we're going to scale up capacity in health force, we need private sector players to come into healthcare training, development of the resources. If we're able to, develop this infrastructure, we need healthcare, we need private sector investors to come in to partner with governments to be able to develop this infrastructure. And lastly, if we're able to improve efficiency, there's no better way to do this but through technologies. And we need private sector players to come in and to provide digital solutions like telemedicine, like e-learning platforms to bolster healthcare access and services across the continent. Once more, I would like to reiterate our commitment to provide financing support across the country, Nigeria, and other member countries. Debt financing, equity, project preparation. We have a bouquet of programs that we could make put at the disposal of private sector actors willing to take advantage of the opportunities, because I believe these are opportunities. I believe the COVID-19 pandemic has created opportunity for players, local players, to kind of step up and fill the gaps, some of the gaps that are existing within the healthcare sector. And I believe that we need to work together with government to be able to find the solution. It might not be the traditional solution, but sometimes you need to just be innovative. Thank you.
Yeah. Thank you very, very much, Ms. Doherty. Like we mentioned at the beginning, one of the key outputs we expect from this event is creation of that relationship platform, right? Where we start bringing together everybody, you know, on one table, public sector, private sector, development sector, to deepen this conversation. So I'm sure a lot of the areas you mentioned, there'll be loads of questions and interest, and, you know, we'll be helping, I guess, expand the conversation. So quickly, we know again that when we talk about additional areas of finance and looking at what we can possibly get, a lot of times, things come up that have to do with taxation. Either tax passed down to the people, or tax that is taxed on, you know, those who provide goods and services. You know, we've had conversations around, if you look at gambling and health-related effects of gambling, and saying, can we start looking at generating some money from that? Again, knowing that that's not going to fully fund UHC, but at least to continue to increase the pool. Telco is another area, you know, where we've looked at, and we said, look, if you look at the size of the telecommunication sector in Nigeria, you know, as little as a 1% charge on the cost of calls, you know, and whether it's passed down to the company or to us, the users, and all that is a discussion for another day, you know. But are these opportunities that we can leverage? Then when you go to crowding in the private sector, there is the creating an enabling environment. And one of the things we would also like to see in the sector is, how do we create incentives for private investors? You know, Afriexim is a DFI, but there are individual and institutional investors who were competing with Ghana, Kenya, and all that to pull these people in. So the more incentives, reliefs we're able to offer, you know, the more likely we'll be able to bring these people in. So I'll be moving over to the Director of Tax Policy from FIRS to say, you've been listening to all this, right? How do we start leveraging, as you're working hard to expand the tax space, where can we plug health in and elevate it to that same level of priority we're currently giving infrastructure, agriculture, and ease of doing business? And you can see with ease of doing business, how we've actually made progress in the ranking on ease of doing business. Thank you very much. So, hello? Hello? So thank you very much, Mr. Bojumbola. Hi, Mr. Bojumbola, can we have you online? Hello? Can anybody hear me?
Yes. At the end of.
Okay. Hi. Is Mr. Bojumbola here, or did he drop off?
He's here.
Hello? Okay, so maybe he's having challenges. Hello, Mr. Bojumbola.
He should be on.
Okay, now I can unmute. I've not been able to unmute.
Oh, okay,
I was not
okay,
permitted
okay.
by.
Okay, okay.
Unmute myself.
Thank you very much. We'd like to have your video as well.
Yeah, I think I'm on video now.
All right, sir. So please,
okay, so thanks very much.
6 to 7 minutes, talk to us. Thank you very much, sir.
Thank you very much, Nkata, for that, and thanks for everyone who had spoken ahead of me. I think I'll take the cue from Ms. Barua, who spoke earlier. The funding of Earth all over the world essentially is the primary responsibility of government. And Section 17(3) of our Constitution also makes that very clear, that the state must provide medical facilities for citizens. However, question is, where will the funding come from? Now, the funding of governments in Nigeria is essentially from two sources. That is from commodities and from taxes. Now, one way that government have been supporting the Earth is by way of tax incentives directed at specifically the healthcare sector. For example, small businesses that are providing healthcare who make less than 25 million naira in a year are totally exempt from income tax. Secondly, healthcare items, products, services, medicines are exempt from value-added tax. And I can recall that in the course of the COVID-19 pandemic, the government waived all duties with respect to importation of medical items. However, the second very important area from the fiscal point is the amount of money allocated to healthcare. And this ordinarily will go into area of training of relevant health workers, provision of infrastructure, and particularly research and development. Now that we are having these issues of vaccines, how do we fund our research efforts? In all of this, the question still is, where does the money come from? In recent past, one of the major issues that government have had to contend with, and which is still contending with, is the criticism that we have too many taxes. And it's becoming a recurring music all over town that we have too many taxes. Howbeit, Dr. Ben Akabuize told us that our tax to GDP ratio is about 8%, 7%. I think the best we ever recorded was around 9%, whereas the average across Africa is about 17%. Now, then, how then do we raise the funding? I have listened to the suggestion, probably there could be new revenue sources, and that is true. How do we bring in gambling, for example, as a revenue source for government? How about some, what we call sin tax, taxes in respect of alcohol, tobacco, and all of that? Now, these are issues that we have to look at and do a serious balancing between the number of taxes that we have and the need for us to generate revenue, particularly for Earth. Now, do we now go for earmark taxes like we have for education? We have the tertiary education fund, where companies pay a percentage of their profits towards education. Howbeit, it is very, very difficult in today's world to introduce new taxes because one, the economy is under serious strain. The companies, the entities, the businesses are having serious challenges of sustaining their businesses. And so coming up with another form of taxes might be a very hard sell for the government and may also not be very healthy for our economy, more so that we must be able to attract the investment into our country. So for these reasons, it might be a little bit difficult to begin to look at what sort of any kind of earmarked taxes or for health purposes. But then what can we do? There are quite a number of suggestions that could be looked at. One is, how do we get more private funding into healthcare services? How do we make the environment more attractive to private people to invest in healthcare? Number two is, we have a lot of tax incentives for other businesses. And what this one does for us is that it denies government direct revenue that could probably have been used for very noble purposes like the health sector. So then government may also now be looking at possibility of eliminating or reducing some of the tax incentives that has directly reduced income accruable to government, so that more funding could be released and then be used for the purposes of the healthcare of the population. I think finally, another point that could also be looked at, and of course, this is already in the public space, is the amount of money that government spends on subsidizing petroleum products, subsidizing electricity, subsidizing one thing or the other. I believe that if we are able to objectively look at this and do not bring them back again, this may also free for us a lot of money that could be invested in the healthcare sector. Mr. Moderator, you have given me 7 minutes. I think I'm approaching the end.
Thank you very, 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 very much, Mr. Bojumbola. Not only did you not use up your time, but I think you've also made a lot of healthcare people happy, just knowing that it's not hitting our head against the wall, because most times when we have all this conversation and you want to talk to the tax people, they just say, no. If anything you're discussing has to do with tax, please just go back to Ministry of Health or to whatever office you're coming from. So this is very encouraging. And again, I think what I've really appreciated about this session is the level of openness and willingness to engage, right? From all the panelists and from all the different sectors and backgrounds we're coming from. Please, before I bring in the last speaker, I just want to remind all participants that we're not going to be taking people raising their hands to ask questions. We mentioned that at the beginning to manage time. Any questions or comments you have, please type those into the chat room. We're curating them and we'll put them across to the panelists, but we're not going to have time to have people raise their hands. So please send in your questions and we'll get them answered while we're still on this session, please. Thank you very much. So I deliberately left Mr. Akunle Lebute for the last, just for one deliberate reason. He's an advisor who has over 3 decades of advising governments, private sector, development sector, right? Across several sectors, and I know he used to be the head of infrastructure, government and health for KPMG. So also advising on health issues, you know, from transactional issues to policy and reform issues and all that. So I deliberately left him to the end to say, Mr. Kunle, having taken in all this, right, from all the way from the minister's keynote through to Elaine's presentation, and the fact that evidence only points to making significant progress towards UHC when you have government financing as being the lead, not lagging behind, right? And then the realities as presented by Dr. Okunola and Mr. Ben Akabueze. And then the opportunities with leveraging the private sector, not just to bring in more funding, but to improve technical efficiency, presented by AfriExim and supported again by FIRS, who even gave us more options of what could be possible. But again, the landmines we might have to walk through, given the economy and the numerous taxes we already have. As an advisor, how would you advise that we bring this all together? Like if you were basically asked to help us with this together, to say, how do we move forward, both in terms of increasing this much needed financing and making better use of what we have, which is around increasing technical efficiency. Mr. Akunle Lebute, sorry I'm giving you the hard task, but everybody's task has been hard apart from the moderator.
All right.
Thank
Okay.
you very much again.
Thank you, Nkata. Thank you so much for making it the most difficult task of all. But let me put it in context, and I agree with most of the earlier speakers. I think the key issue is that we have to all agree that UHC, essentially, is largely the delivery of healthcare at the primary healthcare level, which, as we heard from Ben, for example, that is local government and state governments, have that responsibility to drive UHC, at the lowest level possible. Now, really and truly, if I was to advise, and knowing that we have a funding challenge from a fiscal standpoint, I would say we should recalibrate the entire way we look at healthcare. We look at healthcare because as a government funded sector, and that shouldn't be the case. We can actually change the paradigm where you can break up healthcare into various wallets or various subsectors. I say to yourself, where can you get private sector capital to invest in that sector, and under what terms, and what do you need to do to de-risk the sector? So in India, for example, medical tourism didn't happen overnight. The government decided to classify tertiary healthcare investment as an infrastructure play, and said that they should get single-digit funding for more than 10 years to fund healthcare infrastructure in India, and thereafter they were able to attract human capital into the sector significantly, especially Indian doctors and nurses who are working overseas. So I think we can do the same in Nigeria, where we shouldn't leave tertiary healthcare as an exclusive domain of government. When I say exclusive domain, there aren't any fairly significant tertiary facilities in Nigeria. 100 beds, 50 beds, those are not significant investments. UHC in Badon has 1,000 beds, for example. Luth in Lagos has 800 beds. What stops the government from saying, UHC, I want to take 400 beds out and hand it over to a private sector operator and run that 400 beds for me at world-class level. It will make money. You pay a concession fee to the public side of UHC, for example, to your UCH, or into government coffers, and that money can be used for UHC. And that company that actually runs that facility will make profit and pay taxes to FIRS. The whole ambience of that private sector run tertiary facility will require drugs and equipment and all kinds of stuff. So you begin to see healthcare as a multiplier effect to the economy, and not just as a subsector that government should fund as if it's a social service. The same thing too, you can also do at the secondary care level, where state governments too can say, I want to partner with private sector participators, at the secondary care level. Primary healthcare is much more challenging. You cannot make money in primary healthcare the way you can make money in secondary or tertiary healthcare. Let's be frank. Maybe primary healthcare in urban areas possibly, but primary healthcare in rural areas you can't make money, and you won't get equity investors or debt capital to fund primary healthcare, especially in the rural areas. So let's be. But the point is that once we are able to really infuse large chunks of private capital into the sector, both at tertiary level and secondary care level, the multiplier effect of pharmaceuticals, life sciences, equipment, and so on and so forth, and all kinds of innovative financing. I know there's a scheme in Kenya, for example, where they got 50 secondary care facilities, got all the diagnostic equipment of MRIs and CT scans, and the government guaranteed the lease payments against the cash flows from those 50 facilities. And as a result, it's only got world-class diagnostic facilities at second care level, which therefore drove traffic there rather than taking traffic to tertiary care. The problem we have in Nigeria today is because we don't have proper primary healthcare facilities at the lower level. Everybody's going to a tertiary facility just because they have a cough or because they have malaria or typhoid, which is primary healthcare. I hear that in Kano, for example, at the General Mohammed Hospital, if you get there at 4 o'clock in the morning, you'll see a queue of people waiting to do their blood pressure, all because there's no primary healthcare facility near where they live. So there's a complete, reversal of the way we operate the healthcare system in Nigeria that needs to happen, such that if you then are able to do what I'm talking about, you may find that you can free up resources that can be available for you to put into UHC. Okay, even the money that federal government spends at the center, to be honest with you, apart from looking after their tertiary healthcare facilities, I don't see why they should be funding the primary healthcare agency, for example, or so on and so forth. All that money should go into UHC directly, and working with state governments and local governments to really improve the primary healthcare. Now, the biggest challenge I have is that even if you had all the money tomorrow for UHC, the operational and financial discipline to run primary healthcare at local government level today is much to be desired. There's just isn't a capacity anymore at local government level to run primary healthcare facilities. So even if you decide to do so on a cluster basis or regional basis, for example, I'm not so sure that you have the facility, the human capital and the expertise to run those things, properly and efficiently at high quality. So there's a big piece of work that needs to be done around getting the right level of, paramedics and nurses and doctors that will provide the services at the primary healthcare level throughout the country if you want to do HCO on a massive scale. So overall, I don't think I've seen anything different from what you've heard altogether, but I think the most important factor I have seen in many countries is the political will to get it done. Lack of political will means that we're just doing so because we want to make people feel as if we're doing something in the healthcare space. The best example, of course, is after the Second World War, the UK government decided to set up the NHS and put significant money behind it, behind that political will. And today, the NHS is the second largest employer in the world after the Chinese army. 1 million employees in the NHS. And of course, the NHS is a large economy and it's a large contributor to the GDP of the UK economy, not only for domestic customers, but also foreign customers who come and use the service as well, or benefit from the skills which are also made available in private sector facilities in the UK system, as a result of the best medical schools and the best R&D facilities and so on and so forth. So we need to see healthcare as a very significant contributor to the economy and as a business. And if you do that, and we craft the right policies to attract investment in that sector, we will see tax revenue coming from companies that operate in that sector. We will see investment in human capital. You will see investment in technology and equipment that will happen. And therefore, you see a reversal of medical tourism going overseas, coming back into Nigeria, and hopefully reversal of the human capital going. I hear that on a monthly basis, you probably have 100 doctors jumping on airplanes going abroad to Canada and the UK and Australia. And we need to invest significantly in this sector to be able to drive that traffic back into Nigeria. Now, what's the time frame? I would say we should give ourselves a minimum 10 years for this to happen. But if you have a political will plan over a 10-year period, doing some of the things that we had already on this call, plus what I'm also saying as well, incrementally over a 10-year period, we will get to a fairly significant level of UHC coverage. I don't think we get to 100%, but you get to a significant level of UHC coverage backed by a world-class tertiary facility sector, private sector participation, also in secondary care as well, and then you attract the skills back, or retain and attract skills back into the sector for the country as a whole. But overall, it needs political will, and that political will must not wane. It must be consistently, put in place for it to happen. I'll give you one last example. There's a book written about how malaria was eradicated in Italy. It took 40 years for the Italians to eradicate malaria from Italy. Doing all the things they needed to do to get malaria out of Italy. So for Nigeria or African countries to actually embark upon the UHC journey, you need the political will to make it happen. You must follow it consistently for at least 10 years in the first instance. Thereafter, he'll take a life of his own. Thank you very much.
Thank you very much, Kunle. That's a very solid way to wrap this session up. Political will, and actually no country in the world has made any significant progress towards UHC without it starts as a political commitment, and then that will and the follow through. I will hand over to my colleague, Dr. Maria Saleh, who is the head of the Public Health Thematic Group of the Health Policy Commission of the NESG, to take us through any questions you might have. I think there are just probably 2 or 3 questions so far, and we'll see who that is directed at, and we'll wrap up. Sorry, we've overshot the 2-hour time, but I'm sure we'll wrap up by latest 10 minutes past 2. Thank you very much.
All right,
Maria,
thank you, Dr. Nkata. Can you hear me clearly?
Yes.
All right, so we do have quite a few questions. So I'll just start with the question for Elaine, a question for Elaine. So Sam wants to know, since there is no magic pool funding from the private sector, what is the way forward in Nigeria where government budget is low for healthcare?
Okay, tough question. But here's the thing. When we say government budget is low, health fights for resources with everything else. So it is true the economy has contracted. However, within the money we have, there could probably be more money allocated to health. It is, as we say, the squeaky wheel that gets the oil. Typically, health has not been very good at squeaking. Health is seen often as a black box. So there's a role within our ministries of health and our health sector. Something that Mr. Adeleke just mentioned, we have to create an environment where health is not seen as a black box. It's seen as achieving specific outcomes. It's seen as a potentially large employer. It's seen as an opportunity for investment, for partnership between government and private sector. We have to change the image of health. It needs a makeover because it has to become attractive. When it's attractive not just to the private sector, it's attractive to government, it's attractive politically, then it can attract more resources. It's part of the work we have to do within a Ministry of Health is creating that enabling environment. The second thing would be, we do have money now. We know we don't have enough money. No Ministry of Health in the world ever has enough money. But we can almost always do better with the money that we have. We can almost always do better public financial management, making sure that money that we have is money that we're spending. The worst thing, the worst crime almost, Ministries of Health commit, and it's everywhere, I'm sure it's not just Nigeria, many countries experience this, is they complain that they don't have enough money. And then at the end of the fiscal year, they return money that's unspent. And of course, the Ministry of Finance thinks they're not serious. And then there are consequences to that next year. So there's work we have to do in our house, within Ministries of Health, within the health sector, and there's work we have to do to change and improve our environment and our image to the rest of the other sectors. There's also partnerships that we don't leverage. One of the comments I mentioned in my comments, we shouldn't be thinking that when we say government needs to spend more on health, therefore it all needs to be Ministry of Health. There are other sectors that have a huge impact on health and improving health. Water and sanitation, education, those are ministries where there is potential for them to contribute to what we're trying to achieve in health. Are we taking advantage of those potentials? Are we identifying those partnerships, those collaborations, those responsibilities in those ministries, particularly water and sanitation education, can have a huge impact on health. If people have more water, better water, less infectious diseases, that reduces the burden for us in health to cover the cost of treating infectious diseases. So it's a virtuous cycle. So that would be my response.
Thanks, Elaine. So the next question is from Olufunke to Ms. Doherty. She's saying most of the PPP examples I've seen have been focused on tertiary services or upstream services. Primary healthcare services are closest to the people and have been the most disadvantaged in terms of accessing finance. So what can be done to crowd in private investment into the primary healthcare system?
Thank you, Maria. I think it's more of looking at healthcare sector and trying to change, the mindset of how it is viewed. Primarily, the primary healthcare sector, for it to be seen as something that can be viable and sustainable for Ministry of Health, they've done quite a lot, in recent times. They've tried to create enabling environments to be able to attract private sector, but more needs to still be done to say to private sector, come in. You can work around with, polyclinics. You can develop polyclinics that would address the needs of primary healthcare needs. So these are some of the things that can work. You can get private sector to come in to be able to provide this support. So for me, I think one of the key things, the first one is creating the enabling environment to attract private sector into the primary healthcare. Then once this is created, you'll be able to attract more funding in. There are lots of private sector investors that would be willing to play in that role. And there are lots of private sector investors who don't even necessarily want to play at the tertiary or secondary stage. They just want to have lots of clinics, polyclinics to serve communities, to serve regions, but they need to ensure that whatever investment they are putting their money in is going to be viable, sustainable, and then they can get the returns they desire. So I think the first thing and the most important thing is putting in this enabling environment. Then you can drag in private sector investment into this sector. Thank you.
Thank you so much. So the next question is to Mr. Ben Akazwibe, DG of the Budget Office. So the Budget Office has captured commitments even of the donors. So are there mechanisms within your office to capture private sector contributions to the health sector? Hello?
Yes. Basically, we're setting that up, but it's only to the point that government is involved in the implementation, and it's possible to properly record that. Treasury is the way government accounting traditionally works. It's only funds that are received into the treasury that get accounted for and recorded. But as we fine-tune the framework for accounting for development partner interventions, some of which are in kind, the same framework will extend to private sector contributions, where of course those private sector contributions are in support of government-owned programs or projects, as distinct from programs or projects that the private sector wants to put its own label on. So that's basically what I'll say. But while I have the opportunity, I just wanted to also underscore a point. I think it was Dr. Nkata that made this point. Yes, hitherto, we've been only focused on measuring inputs into the health sector and not as much effort in measuring outputs, and worse still, even in measuring outcomes. But this is something that features in our discussions with the health sector. It's always, oh, you're not spending enough money on health. But the sector needs to commit also to measurable targets for moving the needle on some of the key indicators. So I mean, if we keep throwing money at it, but the infant mortality rates, maternal mortality rates, all of those things are not moving, then it becomes a sort of disincentive. It weakens the case for more investment, public investment in the sector. The other area that needs to be measured is even, I mean, the human, the human resource contribution to delivering good health. You can have all the infrastructure, have all the healthcare, but if the human beings who serve, the attitude to work and all of those things, the work ethic remains what it is, then we're not going to see much value for the the increased investment.
Thank you very much, sir. So the next question is for Mr. Bonjubola. I hope I didn't murder your name, I apologize. For increasing general government revenues, and improved efficiency of tax administration by the state inland revenue boards is a key lever. Does FIRS play any role in technical assistance to the states to enable this?
Yeah, thanks very much. Yes, indeed. We have a body called the Joint Tax Board. The Joint Tax Board is made up of all the 37 internal revenue services, that is the 36 states and FCT, and the Federal Revenue Service. The executive chairman of the Federal Revenue Service is the chairman of that board. And that board is used as a platform for many things. One of them is providing training for tax officers at every level. That's what we call the tax inspectors training, which is all the time facilitated by the FIRS for all tax officers in the Federation, including officers of the state internal revenue services. We also have a platform for exchange of information, whereby the Federal Revenue Service have a channel for exchanging relevant information to the state's internal revenue services for their revenue generation activities. And then apart from this, we have what we call liaison. This is where we dedicate specific focal officer to attend to the needs of state internal revenue services in the FIRS. So in a nutshell, to answer your question very briefly, is the fact that yes, we have that capacity, we have been doing that, and we believe that we'll continue to do that for the foreseeable future. Thank you.
All right, thank you so much. Yeah, it's quite enlightening to hear that. Another question for Ms. Doherty. One of the key deterrents to investment in healthcare is the lack of security of returns. If returns cannot be guaranteed, people will not invest their money, time, skills, or commitments. How are we going to guarantee that investment of capital and human resources in healthcare will generate benefits for the investors and healthcare professionals?
Thank you. It still boils down to my first earlier comments of viewing healthcare differently, seeing healthcare as a sustainable and a viable venture, looking at healthcare and seeing what role, the government will need to play to be able to support and attract investments. Because like I said earlier, nobody's going to bring in investment if they are not sure that they are going to be able to make returns. And one of the key things that I've noted that government has tried to do recently is to come up with specific incentives, incentive and privileges to private sector investors to be able to support them in, to promote investment in healthcare sector. More still needs to be done, definitely. And I know there's been a lot of discussions going on with the Ministry of Health to sort of, come up with more incentive privileges to be able to attract private sector investment, and also regulatory support also to create a good environment for private sector investors who invest in healthcare to be able to make their returns. But one of the key things that, we also need to understand as private sector investors is that the healthcare space is very wide. There are so many ways, or there are so many sectors or sections or areas that you can invest in that you can get viable returns. It's just a matter of us looking at it beyond hospital infrastructure. It's a matter of us looking at other means or other areas or other sections that the distribution, the pharmaceutical distribution support, for example. There is the education support, for example. There are lots of people requesting, for trainings for healthcare practitioners that are not obtainable, that people fly out to get. There is also the technological angle. and the various opportunities that exist for technological companies. So it's for us to do our homework and see where these opportunities exist. And I said earlier, COVID pandemic has created greater opportunities for us. We were all locked down, we could not travel. So it forced us to look inwards and try to see what can we do to be able to have our homegrown solutions. So I think there's no better time than now for private investors to be able to come into healthcare. And there's no better time than now for government and private sector to have an in-depth discussion on what is required to ensure that these businesses can be viable and sustainable. Because at the end of the day, even financial institutions like myself, even as DFIs, one of the key things we would like to see is if we are going to be funding projects, either providing debt funding or quasi-equity funding or equity funding, you want to be able to be sure that the projects you are funding would, be able to generate adequate and good return on investment to their developers or promoters in the long run. Thank you.
Thank you so much. So that last question came from Dr. Odulana. Dr. Olumide Okunola also wants to add to that.
Thank you, ma'am. Just to quickly say that perhaps one thing that we need to emphasize is that all the financing we've been talking about needs to be pulled somewhere. It's when you're able to pull at scale that all of the things Roti and Mr. Lebute has been talking about will become realizable. That's when you are able to have a purchaser. So you have either a purchaser at the state level or a purchaser at the national level. Somebody needs to be able to aggregate such funding. That is one piece that seems to be missing, and I think that is something that almost all the panelists are chipping at the edge. So, and by the way, when we talk about NHIS or talk about the state insurance agencies, that is the kind of role we expect them to play, where someone is able to aggregate all of the millions of individual transactions that happens when we do out of pocket. When somebody aggregates that, then you are able to make a business case. So somebody asked a question about private sector participation in primary care. That shouldn't be a problem, because once you have somebody who is buying that services from the primary health services, then the private investor knows that his returns and somebody is ready to offtake those services that he has delivered. So that's why the reform of health insurance beyond receiving the public financing that we're talking about needs to evolve into much more of a strategic purchaser of services. Putting this in another way is saying, whilst the public financing will be critical for financing, either public or private can actually provide those services. But we need somebody to be able to be the purchaser for all, to be able to pull all of the financing that we've been talking a lot about on this call, and then buy the services downstream. I think it's important that we just emphasize that. That's what brings the demand and supply side together. Thank you.
All right, thank you so much. Dr. Nkata, I think we can stop here. We have a few more questions, but I think the panelists have touched on most of them in their responses.
No, thank you very much. We need to manage the time. We've pulled very busy people out for over 2 hours. So I will hand over to Dr. Ola Brown. Dr. Ola Brown is the head of the Health as a Business thematic group of the Health Policy Commission of the NESG. Dr. Ola, please just jump in and then wrap up so we can shut down for the day. Thank you very much, everybody.
I'd like to start by thanking everybody, the participants in the audience, for the lively discussion. I've been looking at the chat and it's been so exciting, and I just apologize that we couldn't get round to all the questions, but there's been a really lively discussion there on the chat. I'd like to thank all our panelists for their time. It's not easy to give out 2 hours on a weekday, so thank you very, very much for coming in. Your Excellency, the Minister, thank you so much again for your contributions and time. This has been an amazing discussion, and as a medical doctor, also just completing my master's in finance and economics, for me, it's been fascinating to see how sort of my clinical experience and expertise in hospitals all over the world kind of combines with the economics and financing constraints that we face in Nigeria. And I think that that's what everybody in their own different ways has touched upon. I'm also a healthcare investor with investments in almost every area of the healthcare value chain, from pharmaceutical manufacturing to retail to telemedicine, to medical logistics to biotechnology. So it's been very interesting for me from a private sector perspective, listening to the stakeholders, the policymakers. And I think some of the most interesting points from Elaine, who set the scene, were around public financing and the importance of that. I think sometimes we forget the fact that no healthcare system has achieved universal healthcare without that public sector piece, and we can't forget it. And she also emphasized the importance of systems. While Mr. Olumide from the World Bank spoke about innovative financing, and the fact is that, you know, we don't have a playbook for the kind of economic challenges that we're facing in Nigeria and many emerging markets today. So we have to explore ideas that perhaps haven't been explored before, and there's a need to experiment with these things. So I thought that that was a fascinating point. His Excellency, the Minister, also reinforced the need for a multi-sector approach with the donors on one side, with the private sector on the other side, and with the public sector collaborating to achieve this one goal. Mr. Akabueze, you know, pointed out that, you know, it's not all doom and gloom. I think a lot of healthcare discussions, when we start reeling off the statistics about maternal mortality and about child mortality and about the number of doctors, doctor-to-patient ratios, etc., it makes for a really, really gloomy, borderline depressing conversation. But Mr. Kabuese pointed out that, you know, progress has been made, and actually the healthcare budget has doubled since 2015. And I think another important point he highlighted is the political dimension. Throughout, I grew up in England, and the NHS was a huge deal at every single election. It was something that people, you know, lost elections on if they didn't support the NHS. It's a very, very topical and emotional topic for the average UK voter across the country. And as you can see with Obamacare versus Trumpcare versus Medicare versus, everybody knows these systems because, again, they're very, very emotive topics for the average American voter, and it can make or break a politician. But as Mr. Okabueze pointed out, in Nigeria, healthcare isn't really a make or break issue for any politician. And because of that, I think that perhaps healthcare has been neglected because it's not something that people particularly ask for. It's not particularly something that people are passionate about. And that's not an excuse for not providing it, but that could be some of the reasoning behind why we haven't gotten as far in our healthcare delivery as we'd like to. Ms. Dorothy from Afrexim Bank brought back and mentioned the private sector and the various programs that they have within the bank to support the healthcare sector and the role of the private sector, the efficiency that the private sector brings to bear in healthcare. And Mr. Mohammed Nami from FRS, you know, again, with innovation, spoke about things like syntax, syntax for gambling, for instance, that could syntax for tobacco that could increase the amount of fiscal space available for healthcare financing. And finally, Mr. Kunle Elebute brought everything together by talking about this hybrid model and ecosystem approach to healthcare, whereby we should look at other models from other countries such as India, and I think he mentioned Peru as well, and also look at a model that is more all-encompassing and shift some of the traditional ways that we're used to doing things in healthcare in a different direction. So I think a good suggestion from him was looking at the role of perhaps private sector players coming into government assets to increase efficiency. So in summary, what have we really learned? I think a lot of the discussion was focused on hospitals, but I did like the contributions around primary care, because as we know, primary care is the foundation of any functional healthcare system. And when we get primary care right as the most cost-effective way to offer care, I mean, 90% of all consultations in Nigeria are primary care, or should be primary care consultations. They could be solved in a primary healthcare setting. So once we've gotten primary healthcare right, we've solved over half of the problem. We've also raised the issue of our fiscal challenges and trying to, find areas that we can increase the fiscal space. And that's difficult with our budgetary constraints, but I think, innovation has been the catchphrase throughout. Every single speaker has spoken about the role of innovation and out-of-the-box thinking in solving our challenges. We compare ourselves to India a lot, and there are a lot of comparisons to India, but only 5% of Indians by population live in extreme poverty. Over 60% of Nigerians live in extreme poverty. So we need to start thinking about, these unique solutions for our own environment. And what's that going to look like? We spoke about world class, but what does world class really mean in terms of what Nigerians can afford, what Nigeria can afford? Can we afford to replicate exactly what the NHS is doing? Is that world class to us, bearing in mind that our federal budget is about $2 billion, or just under $2 billion, according to Mr. Kabweze, whereas the NHS budget is closer to $250 billion. What does world class mean? What is the package that the Nigerian healthcare system can afford to give to its citizens at this stage? And I think in the very, very open, first remarks from Mr. Yinka Sani, I think he brought to bear a similar sort of narrative around what does world class mean and what are we really aiming to give to our citizens. So I'd like to end on the first note that I started with by saying thank you. Thank you to the board members that showed up. Thank you to the panel. Thank you to Your Excellency, the Minister, and thank you to the wonderful audience. And just a few comments about NESG. NESG is always, as always, very, very open to having volunteers, either for the Healthcare Policy Commission, either under the group that I lead as Healthcare as a Business, or Dr. Maria, the Public Health group as well. So if anybody wants to volunteer, please send your details in, and we'll make sure that you can get involved in some of the larger work that we're doing as well. I also wanted to talk about the NESG conference that you can find details of on our website, and they'll be putting up details shortly on the NHG. This is a pre-conference to the main conference. So if you're interested in attending the main conference, that I would highly recommend, then please get in touch with the NESG team as well, and they'll send the details out to you for that. Thank you all for your efforts and your time and your passion in terms of really working towards, it's conversations like this and the actions that follow them that really change the trajectory of sectors in Nigeria. And that's the only way that trajectories have ever changed. This is the only way, by gatherings of like-minded people. This is the only way where change, the only way that really makes change happen. So thank you for being part of that change today. And thank you for your time. Sorry for overrunning, and enjoy the rest of your day. I'll just pass over to the NESG team in case they have any closing comments, in addition to my closing comments. But thank you very much. Thank you, everybody.
Okay, thank you very much, Dr. Ola. Sorry, we're also running chats at the back end. So we'll just wrap up for the day. It's been almost 2.5 hours. So we'll let everybody go prepare for the weekend. The link has been put up for how to join the Health Policy Commission. So we look to welcome as many of you as possible. This is just the beginning of the conversation. So please, we'll be reaching out. Keep your doors open. Hopefully we'll walk the talk together. Thank you very much, distinguished panelists, participants. My name is Nkata Chukwu. I'm the facilitator of the Health Policy Commission, working with Drs. Ola and Maria. Do have a great day. Bye.